So an IVF cycle itself, from the time that the patient starts taking medication until the time that she finds out if she's pregnant, is about 1 month. And the first, I would say, 8 to 12 days are the controlled ovarian hyperstimulation, in which the woman takes injections of follicle stimulating hormone or LH hormone and several other hormonal injections to try to get her to make several eggs all at once. Once the ovaries look to be in this way, when the follicles are a good size, we think that we will be able to retrieve mature eggs. So then the patient undergoes an egg retrieval. So this is a transvaginal ultrasound guided procedure. The patient is usually asleep for this procedure by using a transvaginal ultrasound probe and using a kind of long 17 gauge needle to go along the probe, traverse the vaginal wall, enter into the ovary. We drain the ovarian follicles. The fluid goes to the embryologist and they look for the egg. And so we do that on both ovaries. The patient may have an embryo transfer approximately 5 days later, or she may have an embryo transfer at some time in the future, whether it be months or years from the time she has the eggs retrieved. And this procedure is very simple. It requires no anesthesia. Essentially what happens is the embryo is loaded into a catheter by the embryologist, and then the physician uses a flexible catheter to go through the cervix and then places the embryo into the upper uterus. There are 2 ways to fertilize the eggs during an in vitro fertilization cycle. The first way is called conventional insemination. And so what that means is we will get the eggs from the patient, and the embryologist puts the eggs in a petri dish and may put thousands of sperm around the egg. And essentially what happens is over the course of several hours, the sperm basically enter through the zona pellucida, or the surrounding of the egg itself. The other option is to do something called intracytoplasmic sperm injection, or we call that ICSI. And in that situation, the embryologist will take the egg after it's been retrieved from the patient. They remove some of the cells from around the egg, and then they use a very small needle to actually place the sperm directly into the cytoplasm of the egg. This sperm that is used for ICSI can be either from an ejaculate sample, or an ejaculate sample can be surgically retrieved from the patient. And the sperm that's used for ICSI can be either fresh or frozen. Indications for ICSI include very poor quality sperm, azoospermia, or no sperm found in the ejaculate. We also think that there can be changes in the structure of the egg when those eggs have been frozen. And so a third indication for ICSI would be fertilizing eggs after they have been frozen. Another reason that we use ICSI may be for pre-implantation genetic testing of the embryo. And finally, we will often use ICSI in an IVF cycle if the patient has done a prior cycle, maybe where they've had less than expected number of eggs fertilized, or if there's been a failed fertilization, which is when no eggs have been fertilized. But we also have to be thoughtful about limiting use of ICSI and making sure that we're using it only when we know that there is a benefit. And the reason why we want to be thoughtful about using ICSI is that there could be a slightly greater risk of birth defects when ICSI is used in couples who don't have male factor. It's also important to understand that if you ever had a patient who had something like cystic fibrosis or a Y microdeletion, or maybe even something like Klinefelter's, that couple is having genetic counseling performed so they understand the risk of potentially passing on the disease as well. And for our patients who are paying out of pocket for IVF, or even potentially with some insurance coverage, there can be an extra cost to ICSI.
So I was just going to show people how we actually perform ICSI. And so here, this is a small pipette. It's about 5 to 6 microns in width. The sperm is actually taken up and is actually brought by the injection pipette very close to the egg, and then it actually is brought in and penetrates the egg. And you'll see here the process actually involves breaking the cytoplasm. So you'll see the cytoplasm of the egg just pop there and actually be injected in to the egg. So you'll see the sperm actually come down now just from the right-hand side into this pipette, and you can see the egg now has actually the sperm placed inside it. And if you actually look at this egg 20 minutes later, you would not even recognize where this hole was actually placed into the egg. Actually, it's very, very rare now that an egg is actually damaged. So once you've actually performed this technique, the eggs are taken away they're actually cleaned and put into our special growth media, culture media, and then actually the following day we actually check for fertilization.
So right now we are talking about 3 different types of genetic testing. One is called PGTA, and it's A because that stands for aneuploidy. This is looking only for conditions that are associated with an abnormal chromosome number or an aneuploid embryo. This is also the most common technology that we use for women who are maybe advanced maternal age. You know, as we know, the risk of aneuploidy goes up as they get older. The second type of testing is called PGTM, and that is looking for a monogenetic disease. These are things like cystic fibrosis, spinal muscular atrophy, and these patients come to us primarily in one of 2 ways. Sometimes a couple has just done routine carrier screening and they find out that they both carry hereditary diseases and they want to try to lessen their chance of having a child that's affected or a carrier. The other very common way that these patients present to us is, you know, a woman will come in and say, I didn't know I carried this, you know, my partner and I carried this disease and we just had a child that was affected, or we had a pregnancy that was significantly affected and we, you know, we don't want that to happen again. And then finally, there's PGT-SR. And that is what we use for patients who may have a balanced translocation.
The 2 things that PGT does allow us to do more confidently is 1, transfer that euploid embryo, but also to actually transfer a single embryo, which is actually, you know, recommended in most cases, because we know that even a twin pregnancy, and not to mention triplet pregnancies, are very dangerous both for the infant and for the mother.
So the embryos are created with a pretty standard IVF cycle. However, instead of transferring the embryos are grown to the blastocyst stage, and then the embryo is biopsied.
So we obviously grow embryos up to day 5, day 6, or day 7. And what we want in front of us is an embryo that is at the stage of blastocyst development. And a blastocyst has 3 characteristics. It has fluid in the center. At one pole, it has what's called the inner cell mass. So the group of cells that actually will go on to form the fetus or the baby. And then thirdly, you have cells that are actually like the outside of a soccer ball, if you want, which are called the trophectoderm. And those trophectoderm cells are the ones that actually will go on to form the placenta. We don't touch the inner cell mass cells, obviously, but what we actually do when we're taking a genetic test is actually go to these trophectoderm cells and take about 5 to 7 of those. And a blastocyst could have anywhere between 50 cells and 150 cells when we're actually biopsying it. But this is an area of trophectoderm that we will actually go to and actually pull off some of it, take this part for analysis, and the remainder of the embryo is then frozen. So this is called the biopsy pipette. This little red dot is actually a laser that actually helps us take away the piece of cell. So this looks very traumatic, but it's actually not that traumatic for the embryo. So you can see here, if I stop this, you've got now hold of 5 to 7 cells. You can see now the laser is actually shooting at the area where we want to remove the cells. So you'll see now that piece of cell tear off.
Those cells are then analyzed for whatever genetic issue they're concerned about. And then the embryo transfer may happen in the future. It could be 1 month later, it could be 3 years later. Those patients may still undergo a CVS, they may still undergo amniocentesis. So doing PGT does not give them a reason to not do any further testing. There is an impact on fertility and the chance of having a baby as women get older, because women are born with all the eggs they're ever going to have. And that oocyte atresia occurs throughout life and then accelerates after, you know, the mid-30s or the age of 37. So not only do we get less eggs as we get older, but we also get a decrease in the oocyte quality. And what I mean by that is that those eggs are more likely to be aneuploid or be more likely to produce aneuploid embryos or aneuploid pregnancies, which will either A, decrease the chance of getting pregnant, or B, may increase the risk of having a miscarriage, both of which decrease the chance of having a baby. When we have a patient that's interested in freezing eggs, usually we'll see them for a consultation, and we will also try to assess their ovarian reserve so we can try to give them an idea of what their chances are of having a baby from that particular cycle. When the woman is ready to do the cycle, she may undergo a cycle just like any other patient doing IVF for infertility. However, those mature eggs are then cryopreserved or frozen on the day that they are retrieved from her. I always want to make sure that patients understand that, when they go to use the eggs later on, it's almost like you're completing the other half of the IVF cycle. So they still need to have those eggs thawed and fertilized and have an embryo created. They can't just, put the eggs in their body and hope for the best. They actually have to complete the IVF cycle. So the most important factors in determining someone's chance of having a baby with frozen eggs is the age of the patient and then how many eggs she has. If a woman is less than 38 and she can have 15 to 20 eggs retrieved, she may have at least 70-80% chance of having a baby from that group of eggs. Now, as women get older, because each of those eggs has a lower potential to be normal and give her a baby, she needs to have more of those eggs. Now, of course, as you get older, your ovarian reserve goes down, so it gets harder to get more eggs from the cycles. So sometimes the only way to get the amount of eggs a woman needs to have the chance that she wants to have in the future is to have her do multiple cycles and retrieve multiple batches of eggs. So there does not seem to be any increased risk of miscarriage, aneuploid pregnancies or embryos, birth defects from using frozen eggs compared to fresh eggs. The live birth rate seems to be similar, and there does not seem to be any increased risk in pregnancy complications from using frozen eggs.
The vitrification process, what it does, it freezes eggs and embryos much quicker. The whole aim of vitrification is that it tries to minimize crystal appearance in the egg. The techniques we used to use would not remove all the water from the cytoplasm of the egg. And what would happen, those would form crystals and actually break pieces within the egg or the embryo, whereas rapid cooling or rapid vitrification actually avoids that. So what you put in is basically what you get out. We expect more than 95% survival rates from what we actually vitrify in terms of eggs and also blastocysts. This is before freezing. If you've got an egg on the far left side, we put it into a solution which is designed to suck out the water and replace it with a freezing solution. So this is a final egg that actually has had all the water sucked out of it and actually has the vitrification solutions inside. The warming process, so when we thaw them, it's exactly the reverse. So basically, you put it in a mix of this vitrification solution and a normal media. The water goes in, the vitrification solution goes out, and you end up with an egg that is exactly the same as when you actually froze it.